All right, today we're tackling an interesting one. It's an organism that, most of us in the lab don't see every day, but when it does pop up, it really demands our full attention. I'm talking about Weeksella virosa. It's this often overlooked but super important pathogen, and we're going to break down everything you really need to know about it. So, here's the game plan. We're going to follow the entire journey of Weeksella virosa, right from the moment it hits your bench all the way to the bedside. It's going to mirror your exact workflow in the lab. Now, just so you know, all the info in this explainer comes from a report put together by Gemini Deep Search, and the awesome images you'll see are from MicroCanvas. And if you want to dig deeper, all the original sources are right there for you in the linked notebook.
First up, an emerging opportunistic pathogen. Let's start with the big picture, right? What in the world is Weeksella virosa? Is this just some rare bug we file away as a weird curiosity, or is it something more? A hidden threat we really need to keep on our radar?
Okay, so here's the key thing to get right away. This isn't a bug that's going to take down a healthy person. No way. Weeksella virosa is a classic opportunist. It waits for the host's defenses to be down, and then it strikes. It really exploits that vulnerability to cause some serious trouble.
So who are we talking about exactly? Well, the patients who are at the highest risk are the ones with really significant underlying health problems. Think end-stage renal disease, different types of cancer, or diabetes. And when Weeksella virosa does get a foothold in these folks, the infections can be really severe. We're talking sepsis, bacteremia, and peritonitis, some of the most dangerous things you can see.
And this is what makes it such a tricky organism. It's got this dual threat, a real two-pronged attack. On one hand, it can cause endogenous infections, meaning it comes from the patient's own body, often the female genitourinary tract. But on the other hand, it's also pretty good at hanging out in the hospital environment. That means we have to worry about healthcare-associated transmission too.
All right, let's move on. Section 2, first clues from the bench. We know who's at risk, so now let's get into our world, the lab. Imagine a culture plate lands on your bench. What are the very first clues that should make your microbiologist's spidey sense tingle and think, could this be Weeksella virosa?
So you do a gram stain. And honestly, it's not going to blow your mind. You're going to see a pretty standard gram-negative rod. It's not doing anything wild, not showing off any unique shapes. There's really nothing here that's just screaming Weeksella virosa right off the bat.
Okay, but this is where things get interesting, the culture plates. On blood agar, you get these really mucoid, viscous, sticky colonies. Your first thought might be, oh, looks like a Klebsiella. But then you look at your MacConkey plate and nothing. Zero growth. And that combination, the super mucoid colonies on blood, but no growth on MacConkey, that is your first huge clue that you're on the trail of something a little bit different.
Okay, section 3, the identification conundrum. So you've got some great clues, right? Mucoid on blood, no show on MacConkey, that's a strong start. But getting to a definitive species-level ID, that's where the real puzzle begins. And it's a puzzle with its own set of tricky challenges we have to work through.
Now, this table is absolutely crucial for your differential. Take a look. You've got its close relative, Bergeyella zoohelcum, which also doesn't grow on Mac and is oxidase and indole positive, just like our bug. So how do you tell them apart? It all comes down to one key test, urease. Weeksella virosa is urease negative, Bergeyella is positive. That one single biochemical test is your make or break for telling these two apart.
So naturally, we all reach for the MALDI-TOF for a quick ID, right? But here's the catch. With a rare bird like Weeksella virosa, MALDI's performance can be, well, a bit spotty. It really depends on its library. So if all your bench clues are pointing straight at this organism, but the MALDI comes back with no ID or a really low score, don't just throw it out. This is a textbook case for when you need to escalate to the gold standard, 16S rRNA sequencing, to get that definitive confirmation.
Okay, so identifying it is one piece of the puzzle, but the next piece, reporting susceptibilities, is a whole different challenge. And honestly, this is where our expertise as microbiologists really truly shines and becomes absolutely critical for the patient.
If you remember one thing about the susceptibility profile of this bug, let it be this. Weeksella virosa is considered intrinsically resistant to all aminoglycosides. We're talking gentamicin, tobramycin, amikacin, the whole family. This isn't something it picks up, it's just baked into its DNA. And it is so important to communicate this clearly to the clinical team, because an immunoglycoside might be part of their standard empiric therapy for sepsis.
And this brings us to the big question, the one we always face with these rare organisms. What do you do when there are no official species-specific breakpoints?
You look it up in EUCAST. You look it up in CLSI. Nothing. So how do you give the clinician a report that's actually useful when you can't just put a simple S or R next to the drug?
Well, thankfully, EUCAST gives us a fantastic roadmap for exactly this situation. Step 1. You always report that intrinsic resistance to aminoglycosides. For everything else, you can compare the MICs you get to the non-species-related PK/PD breakpoints. You can also check the wild-type distributions on the EUCAST site to see if your MIC looks out of place. But the most critical step, the one that makes all the difference, is number 4. You have to add an interpretive comment. This is where you explain the lack of breakpoints and how you're interpreting the results. It completely changes our role from just spitting out data to acting as a true clinical consultant.
So you've done all this hard work. You've written this beautiful interpretive report. How does that actually guide treatment at the bedside? Let's take a look at what the data from case reports tells us about what works and what doesn't.
When you look at all the published cases together, a pretty clear pattern emerges. Your go-to drugs seem to be the carbapenems and piperacillin tazobactam. They show good activity most of the time, with susceptibility rates up in the 80s. But, and this is a big but, resistance has been seen, so you absolutely have to test each specific isolate. On the flip side, things like ciprofloxacin, not a good bet at all. The activity is pretty poor, so you'd want to steer clear of that for empiric therapy.
And here's something really important to realize. If you go searching through the major guidelines, whether it's the Dutch SWAB guidelines or international ones like IDSA, you're going to come up empty. There are no specific recommendations for treating Weeksella virosa. This just drives home how vital our role in the lab is. Our detailed susceptibility report isn't just helpful, it's often the only tool the clinicians have to guide their treatment choices.
Now, what about kids? Well, infections are super rare in children, but they do happen, and it's pretty much always in severely immunocompromised kids. The good news is that treatment principles are exactly the same. You avoid the aminoglycosides, you lean on drugs like carbapenems, and you let the specific AST results you generate guide the final decision. No different. Okay, last section. We know Weeksella virosa can hang out in the hospital environment. So the big question is, what do we do about infection prevention and control to keep it from spreading to our most vulnerable patients?
You know, the strategy here is pretty straightforward. You basically treat it like you would other tricky non-fermenting gram-negatives, like Pseudomonas. It all starts with meticulous hand hygiene. That's the absolute cornerstone. Then, for any patient who's infected or colonized, you're going to want to implement contact precautions. That means a single room if possible, gloves, gowns, the whole shebang. And of course, stepping up the environmental cleaning. And really, this is the big takeaway when we're dealing with rare bugs like Weeksella virosa. Our job isn't just to run tests and report numbers. Our real value is in providing those smart, evidence-based interpretations. We're the ones who bridge that huge gap between raw lab data and effective, sometimes life-saving patient care, especially when the official guidelines just aren't there.
So that's our deep dive into Weeksella virosa. I really hope you found this explainer useful for your work in the lab. If you did, do me a favor and hit that subscribe button. And hey, we'd love to hear from you. Let us know what you thought or if you have any ideas for other organisms you'd like us to cover. Just drop a note in the comments below. And don't forget, if you want to check out all the papers and sources we used for this, the link to the notebook document is right there for you. Thanks so much for watching.